Delaney.
Hi.
Okay. You hear me okay?
Yeah, can you hear me?
Yeah. All right. Let's see here. So I saw your other email from last night. I don't worry about anything that could be wrong because if there is, I'll see it.
Okay.
So I
Apparently
would
I'm pretty
I would
about
just change it, it's not a big
Yeah.
deal. So that one question definitely is wrong. They just have a typo there. So I'll also have to send that to the higher ups to see if they can fix that for the practice exam.
And then what about that one with the rounding?
There shouldn't be any issues with rounding. Like when you're like I was doing the questions on the test that you're getting ready to take, the just the conversion ones, you shouldn't have to worry about rounding at all because basically what they have for an answer is exactly what you get on your calculator.
Okay. Yeah, that one I was like, there's no way. Like, I don't understand.
Yeah. All right. So let me get on the right page here. Code to get in.
Are we using land school?
No, not for this.
Okay. And then the other one, when do you want me to take it?
What's that?
The other one today? The other math test?
We don't have another math test. It's just this calculation A today.
No, in the other class.
Oh yeah, yeah.
When do you want me
It'll
to
be
take that?
it'll be the same way. Did you want to do them both this morning? Is that what you're asking me?
That's up to you.
Well, let's see how long it takes you to get this one done, and then we'll decide.
Okay.
Because class starts at 8:30, so I don't know. We'll see.
Okay.
All right, I just gotta change the settings to give you more time real quick. So you get what's the amount that you get?
Time and a half.
So the time for this would normally be 30 minutes. So I'm just saying 60 then? Is that what I'm saying?
Yeah, we can do 60. I know it won't take me that long. It just makes me feel better that I have extra time.
Okay, I'll just put 60. All right. All right, I'm going to put your code in this chat box here.
Okay. Okay. And then can I just mute this?
Yeah.
Okay. I'm gonna go take it.
Okay.
You want me to leave my video on?
You can, that's fine.
Okay.
Just good luck. Be careful with reading everything. Make sure you're looking at it just right before you go on.
Okay.
Okay.
Thank you. For this one,
Okay, it looks like everyone's done now. So I'm going to go ahead and open up the math so everyone can see a little bit more about what you got wrong and stuff. Let me just change the settings real quick. Okay, everyone should be able to get in now, hopefully, to see. Does anyone have any questions about anything you missed?
Can you go over the one about ampicillin?
Okay, I'm just gonna, this is the math test that you guys just took. So I just put it on here. I shared the screen so you guys can see. So typically, things that I saw that people did wrong on this test, a couple people had trouble with teaspoons. They messed that up. But the one that I saw a few of you guys miss is this one, number 7. So 5 pounds, 8 ounces equals how many grams? So if you know the conversion ounces to pounds, you know there's 16 ounces in a pound. You would know that this would be basically 5.5 that you're working with right here. So this would be, you know, half of a pound. So 5 pounds or 5.5, whatever you want to say. And then if you divide that by 2.2, and then whatever you get there, you're going to multiply by 1,000. And that's what gives you this 2,500. I think it's 2.5 you get or something. So that was one of them. And then I think it was this one. Number 17 was another one I saw some people miss. With this one, again, it's you got to know your teaspoons because it says the provider has ordered Cefaclor 2 teaspoons daily, and then you got to look at what you have down here on the thing. So that's another one that I saw some people miss. So make sure you review some of these things. Any questions about the math?
Is there any way you could go over that one that you were just talking about a little bit more? Because I did, like the 2 teaspoons was 10 milliliters. So I put that over X and then solved it, but I still couldn't figure out how they got 500.
You guys hear me okay? Because I don't know if anyone's listening to me or not because no one's saying anything. So someone say something.
We're talking.
Yeah, I just asked a question. Can you hear me?
Can you hear us?
My volume is down. Can you hear me now?
Yeah, we can hear you.
Okay, good. My volume was down. I think that was what my
Oh.
problem was.
Can you go over that 17?
Yeah, I just asked if you could go over that, the one with the teaspoons, because I converted the 2 teaspoons to 10 milliliters and solved it out, but I still couldn't figure out how they got 500 for the answer.
17.
Yeah, I think that's what it was.
This one here, the Cefaclor.
Yeah, that one.
Okay. Here, let me get something to write with here. So I do ratio proportion all the time. That's how I do everything. So that's what I'm going to do with this one. So in this problem, you have on your label, it says you have 250 milligrams and 5 milliliters. In the question, it says Jaquan is being discharged home with his mother. You're educating them regarding his antibiotic regimen. The provider has ordered Cefaclor 2 teaspoons daily. So 2 teaspoons, 1 teaspoon is 5 milliliters. So 2 teaspoons would be 10, right? So I'm going to put my 10 milliliters right across from my 5 milliliters basically here. So I'm going to cross multiply and divide. So if I do 250 times 10, so that would be 2,500. And then I'm going to divide by 5.
Went walking at
And
Diamond.
I get 500.
Hey, Diamond, where's that?
Over by Nana's house, that big soccer field.
Over about where?
Nana's.
Oh,
Yeah.
oh, she just walked by.
Hey, Drew, there you go.
Spot.
Did that make sense, you guys?
Yeah, that makes sense. I just didn't flip it from being like I put 250 on top and then 5 milliliters on the bottom. So I like had the numbers. I didn't think about
Have in
flipping.
the right place. Okay.
Yeah.
Okay. You guys understood. I don't know if hopefully you heard me about the other one. What's that at? The one with the ounces. This one, 7. Did you guys understand this?
It's stumped
Yeah,
me.
I just can't math. That's all.
Okay. All right, so I'm going to go ahead and stop sharing this, and we'll go ahead and get into our stuff for today. All right, so I finally got access to the book for this, thank God, because that was getting ridiculous. So I got my book in the mail, and I'm able to get into all of my resources online now for this class, so thank God. Anyway, I got all of the PowerPoints, and I put on the PowerPoints from last week and the PowerPoints from this week. So when you're going into Canvas, I just have them under modules. Hopefully you saw that. That way I'm not, putting everything under announcements because I hate doing that. So the other thing I wanted to tell you guys, this isn't my expertise whatsoever in this class, so I feel bad about that because I feel like you guys are getting gypped a little bit because of that. But I talked to Dr. Silva the other day, and she agreed to come to our class next week, and she's going to be a guest speaker for me, and she's going to teach you about stuff that we would be talking about next week. So you guys can listen to her, and at least she knows what she's talking about more than I do. So that content next week, I just really felt like, wow, I need someone to talk about that other than me because it's just a little bit more than what I know. So she's going to do that. And then I'm working on trying to find someone who could do it for peds as well. So I'll at least have one day that I'll have someone come in, hopefully, to talk about some peds stuff too. So next week we'll see Dr. Silva. All right, so for this week, we're going to start with chapter 4. This has a lot of important information in it. When I looked at test 1, This has a lot of stuff on it from this chapter, so I would really pay special attention to this chapter compared to everything else, definitely. Okay, let me see if I can share my screen here. You guys see that okay?
Yeah.
Okay, perfect. All right, so in this chapter, of course, they always go into all the learning objectives first. So I'm just going to skip over that so you can read that. That's not a big deal. Okay, so in this chapter, they start to get into some of the physiologic changes that happen in pregnancy. So not only you have all these different changes that happen in your body and pretty much every body system. And I don't know if you've ever really thought about that, but this kind of breaks it down in every system on kind of what happens. So we're going to start with the reproductive changes. So pregnancy results in all these different things that happen in all of these different systems, and they happen in order to protect the mother and the baby and also prepare the body for birth. So with the breasts are going to get bigger and they're going to weigh more. They have increased growth of the mammary glands. You have an increased blood supply to them. You have increased prolactin. And because of this increased prolactin that you have, you start to produce something called colostrum. And colostrum is a yellow secretion that's rich in antibodies, and it begins to produce as early as 16 weeks. And so that's why they always want women to breastfeed, because the babies would get this colostrum, and the colostrum will like help them, you know, with immunity towards different things. It'll, you know, be a little bit better for them. Then with the ovaries, there's something called the corpus luteum. This is maintained during the first couple of months of pregnancy, and it produces progesterone. And it does this to maintain the endometrium, which is your thick lining of the uterus. So it does that first, and then by about 6 to 7 weeks of gestation, then the placenta starts to take over and do that instead. And so when that happens, then the corpus luteum degenerates and you don't have that anymore. Then this talks about the uterus a little bit. So your uterus undergoes, you know, phenomenal growth. There are increased levels of estrogen and progesterone, and this helps stop the menstrual cycle when the woman gets pregnant. There is hypertrophy of your cervical glands that leads to formation of a mucus plug, which protects the fetus. And then also uterine contractibility increases, and it also has an acidic environment to inhibit growth of bacteria. Now, I'm going to skip over talking about the cervix. For some reason, I didn't write stuff down about that. And then with the vagina, so it increases in vascularity due to expanded circulatory needs. You also have an increase in vaginal discharge, a relaxation of the vaginal wall, which allows for stretching of tissues to accommodate the birthing process. And then just like we talked about with the uterus, with that being in an acidic environment, same with the vagina. So you have an acidic pH in there, and it inhibits bacteria, but also puts women more at risk for yeast infections, unfortunately. Okay, so then we move on to the cardiac and respiratory system. So when a woman is pregnant, her cardiac output increases 30 to 50%, and it usually peaks at about 25 to 30 weeks gestation. A woman's heart rate also will increase, usually about 15 to 20 beats per minute. And then her stroke volume will increase about 25 to 30%. And then the blood volume also is going to increase in her body by 1,500 milliliters to support the uteroplacental demands. So now you have more of a blood flow in your body than you ever have had. And another thing I thought was kind of interesting with the cardiovascular system, you actually have hypercoagulation that happens during your pregnancy. So it's preparing your body for when you have your baby so that you don't have postpartum hemorrhage. One thing that I do want to mention that they talked about in this chapter in the book is something called supine hypotensive syndrome. So what this is, it can happen when a pregnant woman lies on her back in mid to late pregnancy. So being in this position can cut off flow to the inferior vena cava. And usually it's going to lead to a drop in your cardiac output, and the woman will feel dizzy and maybe faint from this. So that's why, they would rather, women be on their left side, because if you're side lying, you don't have that happening, and usually you have better blood flow and everything. Okay, then we need to move on to respiratory. So with the respiratory system, pregnant women will have a tidal volume that increases. So 35 to 50%. Sometimes they will have a slight respiratory alkalosis. So a decrease in your carbon dioxide levels leads to an increase in pH and a decrease in bicarbonate. This change promotes transport of CO2 away from the fetus. Okay, and then also we have an increase in estrogen and progesterone and prostaglandins during pregnancy. So this causes vascular engorgement and smooth muscle relaxation, resulting in edema. So, when people have a lot of edema, usually they have some other things that go along with it. So things like dyspnea. And then also with this, you can also see pregnant women have nasal and sinus congestion because of this. And then also epistaxis, they can have nosebleeds. Okay, so then we get into a little bit about the kidneys. So some changes in our body when we're pregnant with the kidneys. So you have a renal plasma flow that is increased. You are going to have an increased glomerular filtration rate. You are also going to have renal tubular reabsorption that's increased. And then one other thing they mentioned in the book, proteinuria and glycosuria. This can normally occur in small amounts related to exceeded tubal reabsorption. The threshold of protein and glucose due to increased volume. So then with GI changes, so remember when we talk about the GI system, it could be anything from your mouth to your anus. So it encompasses a lot of different things. So of course, when we're pregnant, we have an increased appetite and food intake. A lot of pregnant women have a lot of weird cravings. Some people crave specific foods, and then other people will have things like pica, which I don't know if you guys are that familiar with what pica is, but it's a craving for and consumption of non-food substances. So you could see people eating weird things like starch or clay or I don't know, weird stuff like that. So when people have pica, typically you're worried that they might be anemic. So I don't know if you guys remember talking about those anemias before. I think we touched on that in adult health too a little bit. But one of those specific anemias, you have pica that goes along with it. And typically once you treat that, then that kind of gets better and they don't want that anymore. Other things that can happen with the GI system, everything kind of slows down. So the GI process relaxes, slows, and contributes to heartburn, abdominal bloating, and also constipation. Some problems that people have during pregnancy would be hemorrhoids. You know, if everything slows down so much and you're trying to have that bowel movement, sometimes you can cause yourself to get hemorrhoids. And then I don't know if you guys remember this or not, but also in pregnancy, people are at high risk for having gallstones or having like a gallbladder attack. It's funny, I've had a couple of people in previous classes who told me that when they were pregnant, they had a gallbladder issue and they actually had to be hospitalized for it. I didn't realize that was so popular in pregnancy, but I guess it is. And what happens is because of these gallstones are really common during pregnancy, it's because you have everything slowed down, like I said. So you would have like this emptying of your bile, and all of that's really slow now. So if that's just sitting there with that stasis, it's going to cause you to get those stones. And so that's part of the problem. And then this also talks about musculoskeletal changes. So some of the things that the book mentions with that is a pregnant woman will have a shift in her center of gravity. So this makes women at high risk for falls. It's not uncommon to see lordosis in a pregnant woman. Do you guys remember what lordosis is?
Like almost like it looks like your back is arched.
Yeah, you have a weird curve to the lower part of your back. Yeah. Other things that can happen would be that round ligament spasm. So estrogen and relaxin increase elasticity and relaxation of your ligaments. And you have this abdominal distension, and it re-stretches the round ligaments, causing spasm and pain. So a lot of people will have that round ligament pain during pregnancy. Okay, with the skin, there's a lot of weird things that happen with your skin in pregnancy. So there's something called linea nigra. This is a darkened line in the middle of your abdomen. So like if you're looking at the woman's belly button, like up top and down below, it's like a huge line down the very middle of their belly. They have this dark line there. And that's just a skin change that happens during pregnancy. Another thing, there's something called melasma. MELASMA. This they call the mask of pregnancy. So this person would get brown pigmentation over their skin that would appear on their cheeks, on their nose, and also on their forehead. And then, of course, we all know, pregnant women get stretch marks, so striae on their abdomen. That's a given. And then varicosities are very common in pregnancy. I know I got some with my twins when I had them. And a couple other skin things that you might see people complaining about would be a lot of women get that facial flushing all the time. And then some people will get really oily skin during pregnancy and get lots of acne. With endocrine system, there's probably more than this that happens with your endocrine system, but I wrote down just a little bit here. So with your thyroid gland, you're going to have an increase in thyroid gland production to support fetal and maternal needs. So remember, your thyroid gland has to do with your metabolism. And so you're going to have increased needs because you have another person inside of you. So this is definitely something that needs to happen. So it does during pregnancy. And then with the immune system, I thought this was kind of interesting. So you know how we always talk about your body has the ability to sense when there's something wrong. Like if there's something foreign to it, it tends to, react a certain way to get rid of it. Well, if you think about it, when you have a baby, why would your body not think this is a foreign thing, So our book was just saying this is an adaptive process that allows the maternal system to become tolerant of the foreign fetal system, and it doesn't reject it. It actually protects it from infection. So I thought that was kind of cool that our body does that. Okay, what cardiovascular changes occurred during pregnancy? So we already said, yes, we have increased cardiac output. We also have edema, and we have an increased plasma volume. So it's going to be D, all of the above. Okay, so this part of the lecture here is kind of important. There's a lot of things in here that I would definitely write down and keep track of. So this talks about preconception care. So if you have a woman who is wanting to get pregnant, if she's saying, okay, this is, when I want it to happen, you have to start thinking about your behaviors and some of the things maybe you do normally that maybe you would want to stay away from during this time where you're trying to get pregnant. So you want to decrease these risk behaviors before you try. So things like, doing illicit drugs, drinking, smoking, excessive use of caffeine, any of those types of things you would want to decrease or stop altogether. And then there's also certain medications that maybe certain people take that are not good for someone who's trying to get pregnant. So you would want to, talk with your physician about that to see if you could get any of that changed or come off of something if that was the case. Also, you want to watch environmental toxins like household chemicals, because they can cause miscarriage or preterm birth. There's a lot of things like that maybe you didn't even think about. And then when this mentions education and anticipatory guidance. So if someone's trying to get pregnant, what is something that we usually say? Hey, you need to be on prenatal vitamins, right? So the prenatal vitamins are really important because we're trying to prevent certain things from happening. Like prenatal vitamins have folic acid in them. So folic acid is going to help reduce the risk of neural tube defects. So that's super important. And there's a certain amount of folic acid that you're supposed to have a day. And it varies from person to person depending on what you're taking it for. But Anyway, so folic acid is part of prenatal vitamins. And then another thing that you might consider too when someone's trying to get pregnant, you want to make sure that they're not anemic. So iron might be an important thing to take. And what do we know about iron? When you take iron, it can cause your stool to do what?
Well, it constipates you.
Yeah, definitely constipate you. But what's your stool look like when you take it?
It's black.
Yeah, it's really dark. So we would want people to understand that that's something that's normal to see with that, and to know that if they do take it and they get constipated, they need to be taking something so that they can go, like stool softeners or whatever, in addition to taking that. So those would be some important things to tell them. Other things to educate about would be nutrition. So we want this person to eat pretty healthy and to try and maintain a healthy weight. If you're obese, it increases your risk for infertility. So I don't know if everyone knows that out there, but so you really want to make a really good effort to try and eat better when you're trying to get pregnant. Exercise is another really important thing. So women can continue to exercise after they're pregnant even. That's totally fine. So they say, things that are really important with exercise, aerobic activity. So walking and running, all of these things will help with weight management and conditioning. That's really important. And then also weight-bearing exercises too. So these can help with bone strengthening and prevent osteoporosis. So any of those types of things would be good to do beforehand and during your pregnancy. Okay, so this is talking about different signs of pregnancy. So they have presumptive, probable, and positive signs. So look what it says here. Presumptive signs is subjective. What does subjective mean?
Like the patient's own words or
Yeah,
statements.
yeah. So it would be things that they tell you that are happening. So like maybe you're the nurse and you're not seeing them happening. You're just taking their word for it that these things are happening, right? So write these down. So some presumptive signs of pregnancy would be amenorrhea. So this means that they're not menstruating anymore. They have not had a period. Nausea and vomiting would be another one. So this is really common during weeks 2 through 12 of pregnancy. This is real common with women. Breast enlargement and tenderness would be another one. Fatigue would be another. Increased urination or frequency of urination. And then the last one is quickening. So quickening is just a woman's first awareness of fetal movement. So usually this occurs about 18 to 20 weeks. And this would be in someone who this was their first baby, about 18 to 20 weeks. And then if you've had kids before, maybe you might feel it a little sooner. So those are presumptive signs. So subjective things that mother or potential mother tells you that are happening. So then we go to probable signs. So now you see this says objective. So remember, objective things are things you can actually measure. So they're things that would back up what you're trying to prove, right? So with probable signs, there's something called Chadwick's sign. So this is CHADWICK''S, Chadwick's sign. So this would be like if the woman goes to her, OBGYN to see if she's pregnant, then the OBGYN could see if this person had Chadwick's sign. This is a bluish purple discoloration of the vaginal mucosa. the cervix, and the vulva. And this you would see about 6 to 8 weeks gestation. So obviously you'd have to have someone who's trained to see that, you know. Another probable sign would be Goodell's sign. So this is Goodell''S. So this is softening of the cervix and vagina with increased leucoreal discharge. And it's palpated at about 8 weeks. Another probable sign would be Heger's sign, Hegars, Heger's sign. So this is softening of the lower uterine segment, and this can be palpated at about 6 weeks. A couple other things, uterine growth and abdominal growth, sure, you know, that would be a probable sign because it's something that you can actually see and possibly measure. And then skin hyperpigmentation would be another thing. And then the last thing is, I don't know how to say this right, ballottement, I guess. It's Ballottement. So when I read about this is weird. So it's a light tap of the examining finger on the cervix. And this causes the fetus to rise in the amniotic fluid and then rebound to its original position. This occurs at 16 to 18 weeks. And then also, you know, of course, positive pregnancy test, and, you know, with like blood or urine would be another probable sign. Okay, and then the last thing is positive signs. So positive signs are things that only are attributed to the fetus itself. So, you know, if the mother went to her OBGYN and they were able to auscultate the fetal heart rate at 10 to 12 weeks with the Doppler, that's a positive sign. Another thing would be observation and palpation of fetal movement by the examiner after 20 weeks gestation. So you're actually able to see fetal movements. And then the other thing would be sonographic visualization of the fetus and also cardiac movement noted at 4 to 8 weeks. Those would be positive signs. Okay, here's another kind of important thing. Okay, Nagel's rule is something that we need to talk about. So usually when someone is pregnant and they come to their physician's office, they do what they call an estimated due date. They try to figure out when this baby is due. So typically they ask you when your last menstrual period was, and if that was unknown, then they would do a physical exam to determine the uterine size. And they would also see when first auscultation of the fetal heart rate was with the Doppler. They would try to estimate the date of when the mother first felt movement, you know, quickening. They would look at the ultrasound exam and the history of assisted reproduction. They would look at all of those things to try and estimate it at that point. But with Nagel's rule, if you know their last date of their menstrual period, you can figure this out. So there's two factors that affect Nagel's rule and that influence how accurate it is. So one thing is how regular the women's menstrual periods are, and also the length of the women's menstrual cycle. Usually, if you do this, it's pretty accurate. Most women give birth within 3 weeks before or 2 weeks after the estimated due date. And then for a normal length of pregnancy, this would be approximately 280 days or 40 weeks. So this would be after the first day of their last menstrual period. So those 280 days would be counted from there. Okay, so to determine this Nagel's rule, what you do is you take the first day of the last period and you count backwards 3 months, and then you add 7 days to that, and then you correct the year if it's necessary. Another thing I would like you to write down too would be the difference between early term, full term, late term, and post term. So obviously, full term infant would be 40 weeks, right? But there's some other things that kind of play a part here as well. So early term is considered 37 to 38 weeks. So it doesn't necessarily mean that there's anything wrong or anything's going to be happening that's not good with the baby. They would probably be okay at that point. Full term is anywhere from 39 to 40 weeks. Late term is 41 weeks. And then post term is 42 weeks and beyond. Okay, so going back to our current slide here. So the book also talks about what gravida and para means. So there is this acronym here, GTPAL, that we need to know. So if you worked in OB and they were, you were talking on the phone with a physician, they may ask you some of these things. So you need to know what all of these things stand for. So gravida is the G. So that's the total number of times that this person was pregnant. So I'll use myself as an example. So for me, my gravida would be 2. For T, number of term infants born. So we just talked about what term meant, right? So let's see if we can figure out what I am. So for my boys, I had them at 38 weeks. So that was early term. So I would say that's okay. Anything in that range would be fine. And then also my daughter, I had her at, I think it was 39 weeks. So I would say 3 then for my T. And then for P, this is para. So this is the number of preterm infants born. So really, I didn't have anyone too early, so I would say 0 for that. And then for A, number of abortions, this would be 0 for me. And then for L, number of children currently living, it would be 3. So that's kind of how you figure that out. Also, the book said that sometimes you'll see an M. The M represents pregnancies with multiple gestations. So for me, that would be 1 for that. And then I just want to give you a couple other definitions so you know what we're talking about here. So there's something called nulli gravida. So NULLIGRAVIDA. This is a woman who has never been pregnant before or given birth. So like my sister. My sister has never been pregnant, never given birth, so she would be nulli gravida. I don't know if I'm saying these right. Primi gravida, PRIMI, and then gravida at the end. This is a woman who is pregnant for the first time. So if someone had never had a baby before, but now they're pregnant, they're primi gravida. And then multigravida is a woman who is pregnant for at least the second time.
I have a question.
Yeah.
Okay, so if there's someone who they've been pregnant, but like they have miscarriages, like they've never been able to carry, would they still be a nulli gravida then? If they're not actively pregnant?
No, because a nulli gravida is a person who has never been pregnant before. So if they were pregnant at one point, but they just weren't able to carry it all the way and miscarried, then they're not nulli gravida anymore.
Okay, and also for the GTPAL, for under abortions, that includes losses, right?
Yes.
Okay.
All right, so then this gets into a little bit about components of prenatal care. So obviously there's 3 trimesters that a woman goes through when they're pregnant. So the first trimester, it'll last until your 12 weeks gestation, right? So during this time, when a woman goes to the doctor to find out that they're pregnant and they kind of go from there, some of the things that they do for care. So during that time, they are going to determine when was their last menstrual period. They are going to ask them when they stopped using contraception. They want to know if that woman kind of has an idea of when her due date is. They're going to try to estimate that due date. Then they are going to do a history. So they'll do that GTPAL with this person. They're going to ask them if they've had other pregnancies before and ask them the length of gestation, their type of birth experience, if they had any kind of complications, what were their neonatal outcomes. They're going to do a physical and a pelvic exam on this person. They're going to also assess uterine growth. And they're going to try to assess fetal heart tones. Usually these are heard by 10 to 12 weeks. And a normal fetal heart rate would be between 110 and 160. And then they also may draw some labs, during that first time that they come. So usually this prenatal care has 3 components. So usually we do early and continuous risk assessments. We do health promotion things with the mother. And then we also do medical and psychologic interventions that we do follow up with as well. So during the second trimester, this is after that first 12 weeks. So when they come for their appointments, so they're going to do a physical assessment, they're going to check your vital signs, they're going to get your weight, they're going to check your urine. Usually they do a urine dipstick. They'll check the fetal heart rate. They'll see if the fetus has been moving. They'll ask about fetal movement. And then there's something called Leopold's maneuver. So what this is, it's palpation of the abdomen to identify the position of the fetus in utero, and they measure the fundal height, and this should equal the weeks of gestation that this person is at. And then they're going to confirm the due dates. They may do some labs and diagnostic testing. Like one of the diagnostic testing things you do in the second trimester is they do that screening for gestational diabetes. And usually that's done at about 24 to 28 weeks. So that's kind of some of the things they do in the second trimester. So the third trimester, now we do more of a focused assessment. We are definitely assessing for fetal movements. A lot of times they'll do what they call a kick count to see, how much this baby's moving. Absent fetal movements can indicate fetal hypoxia and big problems. So you definitely want to, feel movement there and see movement. That Leopold's maneuver that they did in the second trimester, they could do here as well. Another screening thing that they do in your third trimester is they screen for group B strep. And I don't know if any of you have ever had that before, but I was positive for that with my second pregnancy. So all this means is that you have this strep that when the babies come out, they can get it, if you don't treat it. So I had to, before I had my babies, I had to get a penicillin antibiotic. I forget how many times they gave me that, but it was just awful. If you ever have to get penicillin through the IV, it hurts, let me tell you. So I had an IV in my hand, and I felt like I wanted to cut my hand off. It was so bad. And so they would be like, oh, here's an ice bag, and I'd put it on my hand to try and numb my pain, but it was just horrible. Even though it was this little teeny bag, it was awful. So anyway, group B strep would be another thing that they would screen for.
Can I ask a question?
Yeah.
What happens if I were to get pregnant and I would be positive for group B strep? I'm highly allergic to penicillin. What would they do?
They would just give you a different antibiotic. They would try to treat it that way. They just pre-treat you with an antibiotic to try and kill, that bacteria.
Why do they wait until you're giving birth to try to treat it if they're testing earlier on?
I guess it works better that way because you're so when I was, how people can be in labor for varying amounts of time, right? You just want to do it somewhat close to when they're going to give birth. So when I was first in labor, with my daughter, it took forever. With my boys, it didn't take as long. So they just wanted to make sure they gave it to me before they came out. And so I had, some time for that to act. I don't have a great answer for why exactly they have to give it that close. I would assume you would want it in your system, close to when you're giving birth so that it gives better protection to the babies.
All right. Thank you.
Other things in the third trimester, you're going to discuss possible limitations for work and travel. So for me, when I had my boys, I was still working at the time, and I was working my 12-hour shifts, and I was pretty healthy. I didn't really have too many issues, so they let me work all the way through. So they did not restrict me. And then with travel, if you were someone who had to travel out of town, on a plane or something, that probably would, be nixed by your doctor, especially when you're real close to delivery. That's just not a good idea. And then other things you're going to do is you're going to talk about signs of labor. So you definitely want that mom to know what that's like, especially if it's the first time for her. I know for me, it was just weird. So with my first baby, I had to get induced. She just did not want to come out no matter what we did. So I was induced. And so I didn't really feel what it was like to start having, those signs. So with my boys, it was different. I was at work when I went into labor with my boys, and I worked almost my whole 12-hour shift. And like towards the end of the shift, I'm like, wow, I wonder if those are contractions I'm feeling, And I wasn't sure because I was induced before, and I never really had that feeling. So I called downstairs to the OB floor and I asked, someone, and they're like, yeah, come down and let's take a look at you. And so I went down there, and lo and behold, I was in labor, But I never had felt that before, so I wasn't sure. So definitely talk about signs of labor, what's true labor versus false labor. That can be kind of hard for some people to understand. Okay, and then some education things that you should talk about. So first trimester, definitely you're going to educate about weight gain. There's a whole big thing in your book about that. They have this like chart and everything. So you want to set a goal for your mother to kind of like stay, there with their weight. Some people think they can just eat whatever the heck they want and just get as big as a house and be fine. But that's not true. You definitely have issues when you're overweight when you're pregnant. So you set a goal and you try to keep that mother within that goal. So the other things to talk about in the first trimester is to make sure they drink a lot. So you want them to drink about 8 to 10 glasses of some type of fluid during the day. It doesn't necessarily have to be water, but water's probably the best thing. And then you want them to avoid certain kinds of fish. So when they're eating, things like orange roughy, marlin, king mackerel, shark, swordfish, tilefish, all of these things would have an increased level of mercury in them. So that would be bad for the mother. So you don't want them to have that. Then in the second trimester, usually you're going to give the mother some information on fetal development. Usually, that book, What to Expect When You're Expecting, that's a huge thing. Every time people are pregnant, they always get that book because they want to know, during the 8th week, what does my baby look like? What do I expect, So you try and talk to the mother about some of those things during the second trimester. You also are going to talk about nutrition during that time as well and follow up with how they're doing nutritionally and with their weight. You're going to give them information about physical changes that they might start seeing and like different things that they can do to relieve discomfort. A lot of times people will have like back pain and sciatic nerve pain and all kinds of weird things. So there's different things you can tell them to do to help with some of those things. And then another thing you're going to talk about is signs to report. And this would be something that you would also talk about in the third trimester. So things that would be bad that they need to report to their physician. So signs of preterm labor. So this would be rhythmic lower abdominal cramping or pain, low backache, pelvic pressure, leaking amniotic fluid, increased vaginal discharge, vaginal spotting or bleeding. All of those things would be signs of preterm labor. And then the other group of things that you want them to be aware of is signs of hypertensive disorders. So this would be severe headache that does not go away with usual measures, visual changes, and then also facial or generalized edema. So those would be signs of, maybe they have, preeclampsia or something. Then with the third trimester, again, we're going to do some of the same things we do in the other, times. Like you're going to do a nutrition follow-up. You'll, tell them about different things they can do to relieve discomfort. You're going to go over signs of labor so they understand what to expect. And they need to know when to go to the hospital. And then again, go over some of these signs of things to report. Okay, so in our chapter, there is this huge chart. Yeah, here I wrote it down. It's page 88 to 93. It's chart 4-5, and it talks about common physical discomforts and nursing actions to help with those. So definitely make sure you check that out. Okay, so Nagel's rule helps to calculate what? Yeah, it's going to be your estimated due date. All right, and so again, this chapter is pretty important because it talks about a lot of things that you need to know, like those presumptive and positive signs of pregnancy, those things, and that stuff about the gravida and para and all of that. Those are real important things to know, and especially the Nagel's rule with the estimated due date, like how to figure that out. All of those things are really important in this chapter, so make sure you spend some time looking at those. I did put some videos online about some of the stuff that you could look at as well to help you, get some good knowledge about that. All right. I am going to stop sharing a second here. And my plan, we'll get off here again for a little bit and then we'll come back on and I'll go over a little bit more stuff. This week there's like 4 chapters to go over. Obviously I'm not going to go over all 4 with you. I'll pick one other chapter to go over that I feel like is pretty good information that you might need for the exam, and we'll go over that. So let's see, it is 10:16 right now. What time's our class done usually?
3:20, I think it was.
Oh, not
Or
for
you
this.
mean
Not for
you
this
mean for
one.
the? Oh, I think that's all day. I think we broke at like 10:30 last time.
So what time should we
Supposed to
come?
be over at 11:45.
It's supposed to be over at 11:45.
Yeah.
Okay, so let's come back at 11, and we'll do one more thing, and then we'll be done for the day for this class. Okay.
Okay.
So come back at 11. You'll use the same code to get into this Zoom meeting here.
Sounds good.
All right.
Sounds good.
Thanks.